By 2036, the United States will be short up to 86,000 physicians. You've probably seen that headline. It gets dragged out every time Congress debates healthcare funding or a local hospital cuts its ER hours. But the narrative you've been sold about why this is happening is a complete lie. We are told this is a pipeline issue, a math problem, that we simply aren't building enough medical schools or expanding residency slots fast enough to keep up with an aging baby boomer generation. That explanation is comfortable, it's clean, and it is fundamentally wrong. The doctors who will make up that 86,000 shortage aren't missing because we failed to train them. They are already trained. They are sitting in your local clinics right now. They've survived organic chemistry, aced the MCAT, sacrificed their entire 20s, and taken on $250,000 in debt. They didn't fail the system broke them, and right now, in numbers never seen in the history of modern medicine, they are choosing to simply walk away. To understand how a nation's medical infrastructure collapses from the inside out, you don't look at policy white papers or congressional hearings. You look at a suburban driveway on a Tuesday afternoon in October. Dr. Marcus Hale was a board-certified emergency physician with 12 years of attending experience under his belt. He was the guy you wanted on shift when a multi-car pileup hit the trauma bay, calm, decisive, utterly surgical in his focus. On this particular Tuesday, his shift ended at 3 p.m. He drove home along the exact same 7-mile route he had taken thousands of times before. He pulled into his driveway, put the car in park, and turned off the ignition. And then, he just sat there. He didn't cry. He wasn't hyperventilating. He hadn't lost a patient that day, nor was he facing a malpractice suit. He just sat in the dead quiet of a late afternoon suburban driveway for 40 minutes, staring at the closed garage door, paralyzed by a single, terrifying realization. If he opened that car door and walked into his house, he would have to acknowledge that he had to go back tomorrow. And he couldn't do it. Not for another shift. Not for another hour. Marcus had wanted to be an ER doctor since he was 14 years old, after watching an emergency team stabilize his younger sister during a severe anaphylactic reaction. He built his entire life around that single ambition. 4 years of elite undergraduate study, 4 years of medical school, 4 years of brutal residency training, endless board recertifications, night shifts, missed holidays, missed birthdays. He gave up a decade of human life to earn the right to stand in that trauma bay. And at age 42, sitting in his car with the engine cooling, he realized he was done. He wasn't retiring, he was quitting. If Marcus were an anomaly, his story would be a tragic personal footnote, a case of individual burnout in a high-stress field. But Marcus is not an anomaly. He is the standard baseline. Data, released in 2026, reveals a terrifying shift in the demographics of American medicine. The average age at which US physicians are permanently exiting clinical practice has plummeted to 48 years old. That is nearly a decade earlier than previous generations. We are witnessing an unprecedented mass exodus of doctors in the absolute prime of their clinical capabilities. Even worse, the leak isn't just at the top, it's at the very beginning. Roughly 11% of physicians who complete their full residency, people who have just endured over 10 years of rigorous, grueling education, are choosing never to practice clinical medicine. They finish the last day of residency, hand back their badges, and take corporate consulting jobs, go into tech, or abandon healthcare entirely. They endure the entire gauntlet, pay the full price, and then refuse to step onto the playing field. And for those who remain? Current surveys show that 1 in 5 practicing physicians in America is actively planning to exit clinical medicine within the next 24 months. 1 in 5. Think about what that means the next time you sit in a waiting room. Look at your doctor. Look at the specialist treating your parents. There is a 20% chance they are currently plotting their escape route from the profession. When confronted with these numbers, healthcare executives and cable news pundits always point to the exact same scapegoat: the COVID-19 pandemic. It's an easy narrative. We all saw the news footage from 2020 and 2021. Exhausted nurses, doctors in makeshift PPE, overflowing ICUs. It feels logical to assume that the sheer psychological trauma of those years simply broke the medical workforce. It's a neat story. It absolves the system, and it is historically absurd. 5 full years before anyone had ever heard of SARS-CoV-2, in 2015, a landmark study published by the Mayo Clinic revealed that 46% of all American physicians were already exhibiting clinical symptoms of severe professional burnout. Nearly half the entire workforce was functionally compromised before a single pandemic patient ever entered an American hospital. By 2026, after years of headline-grabbing wellness initiatives and corporate applause, that number hasn't disappeared. It remains stubbornly anchored at over 40%, heavily concentrated in primary care, emergency medicine, and critical care. The pandemic didn't cause this crisis. It merely stripped away the romantic myth of the sacrifice. It exposed a lethal structural decay that had been quietly eating away at the core of American medicine for 30 years. So what is actually driving tens of thousands of highly trained, deeply dedicated professionals to abandon their life's work? To answer that, we have to look past the psychological toll and examine a quiet corporate revolution that systematically transformed the sacred relationship between a doctor and a patient into a hyper-monetized, high-throughput assembly line, and turned the most educated workforce in the country into high-priced data entry clerks. To understand how the American medical profession reached this critical breaking point, it is necessary to examine the structural and regulatory shifts that fundamentally altered the practice of medicine over the past 3 decades. The transformation was not the result of a single policy failure, but rather a sequence of federal mandates, corporate consolidations, and economic incentives that systematically redefined the role of the physician. The origin of the current operational crisis traces back to the passage of the Health Information Technology for Economic and Clinical Health, or HITECH Act, signed into federal law in 2009. The legislation allocated over $30 billion in financial incentives to accelerate the adoption of electronic health record systems, commonly known as EHRs, across hospitals and outpatient clinics nationwide. The primary policy objective was straightforward: replace legacy paper charts with standardized digital networks to eliminate prescription errors, streamline communication between facilities, and optimize operational efficiency. While the transition to digital records succeeded in creating an unprecedented volume of health data, the practical consequences for daily clinical operations were severe. Instead of reducing the administrative burden, EHR platforms became hyper-complex billing engines, engineered primarily to fulfill regulatory requirements and maximize insurance reimbursement metrics. Federal compliance mandates required physicians to log hundreds of distinct data points for every single patient interaction, ranging from minute diagnostic coding to extensive quality of care checklists. Time-motion studies conducted across major academic medical centers revealed a profound shift in physician time allocation following the mandatory implementation of these platforms. Research indicates that for every 1 hour a physician spends engaged in direct face-to-face patient care, they now spend approximately 2 full hours entering data, reviewing system flags, and completing administrative documentation within the EHR interface. During a standard 12-hour clinical shift, a practicing physician routinely executes over 4,000 individual mouse clicks. This documentation workload routinely overflows beyond normal clinic operating hours, giving rise to a documented industry phenomenon officially designated by researchers as pajama time. Physicians regularly spend an additional 2 to 3 hours every night at their home computers, completing administrative charts, completing prior authorization forms, and processing electronic inbox notifications. This uncompensated work, performed long after clinical hours have concluded, directly encroaches upon basic rest and family life, creating a state of chronic operational strain. Simultaneously, a massive structural consolidation reshaped the ownership model of American healthcare facilities. For most of the 20th century, the dominant operational structure was the independent private practice, wherein small groups of physicians owned their clinics, controlled their daily appointment schedules, and maintained direct professional autonomy over patient management. In the early 2000s, escalating overhead costs complex billing regulations, and declining reimbursement rates from both commercial insurers and Medicare made independent practice financially unsustainable for many practitioners. Hospital networks and private equity firms capitalized on this vulnerability, executing a rapid, widespread acquisition of independent medical practices across the nation. Industry tracking data demonstrates a dramatic shift. While a clear majority of American physicians owned their practices 20 years ago, today more than 70% of practicing doctors are direct employees of large corporate hospital systems or private equity-backed management entities. This shift in ownership fundamentally altered the internal power dynamic of the medical field. When physicians transitioned from practice owners to corporate employees, their clinical workflow became subject to corporate management protocols focused on volume throughput and financial productivity. Hospital administrators began evaluating clinical output using standardized metrics, most notably the Work Relative Value Unit, or RVU. The RVU system, originally designed to standardize Medicare reimbursement schedules, was repurposed by healthcare executives into an internal productivity metric. Under this model, a physician's financial compensation, performance bonuses, and contractual security are tied directly to the sheer volume of patients processed and procedures billed within a specific time frame. To meet corporate revenue targets, health systems systematically reduced appointment lengths. Standard primary physicians who attempt to spend necessary time with complex patients fall behind on their rigid daily schedules, face administrative penalties, and suffer financial cuts under RVU-driven compensation models. The corporate pressure on physicians was further compounded by the exponential growth of insurance-mandated administrative protocols, particularly the prior authorization process. Designed by health insurance companies to control utilization costs, prior authorization requires physicians to obtain formal approval from a payer before prescribing specific medications, ordering diagnostic imaging like MRIs, or scheduling necessary surgical procedures. To secure these approvals, physicians and their staff must spend hours navigating automated telephone menus, filling out multi-page justification forms, and engaging in peer-to-peer appeals with medical directors employed by insurance companies. According to survey data compiled by the American Medical Association, the average physician now spends over 13 hours every week navigating prior authorization hurdles alone. Over 90% of surveyed doctors report that these administrative delays directly cause negative clinical impacts for their patients, including treatment interruption, disease progression, and avoidable emergency room visits. The convergence of federal documentation mandates, corporate employment models, RVU productivity quotas, and insurer prior authorizations transformed the practice of medicine into an environment characterized by severe administrative friction. Doctors who entered the profession to diagnose and treat human suffering increasingly found themselves functioning as mid-level administrative technicians within a heavily commercialized healthcare apparatus. The structural trap was fully set long before external crises exacerbated the system to its breaking point. The operational breakdown within the American healthcare system is no longer a theoretical debate among policy experts. It is a fully realized crisis playing out across public health statistics, legal filings, and institutional workforce metrics. The structural pressures established over previous decades have culminated in a severe clash between corporate health system mandates, regulatory bodies, and the physical capacity of the physician workforce. At the center of this conflict lies the phenomenon of severe workplace attrition, particularly within high-intensity specialties such as emergency medicine, critical care, obstetrics, and primary care. According to investigative reports and clinical staffing audits, the attrition is not distributed evenly across the medical landscape. Rural areas and socio-economically disadvantaged urban districts are experiencing the most acute deficits, creating vast geographic sectors with severely compromised emergency and specialized medical coverage. In rural health networks across the United States, more than 150 community hospitals have closed or completely eliminated inpatient and emergency services over the past decade. The remaining regional centres operate under perpetual staffing shortfalls, relying heavily on temporary contract labour, known as locum tenens physicians. Health systems incur exorbitant costs to retain these temporary workers, often paying 3 to 4 times the hourly rate of permanent staff. This temporary staffing model creates severe financial instability for rural hospitals, while providing no long-term continuity of care for local populations. Meanwhile, in urban centres, major health systems are facing unprecedented friction between corporate administrative boards and medical staff leadership. The rapid influx of private equity investment into hospital management and specialized medical groups has introduced aggressive cost-cutting protocols designed to maximize short-term financial yield. Private equity firms currently control significant market shares in emergency medicine staffing, dermatology, anesthesiology, and radiology practices across multiple states. Investigative financial disclosures reveal the standard operational playbook utilized following private equity acquisitions. Hospital staffing ratios are systematically reduced, physician shifts are replaced with lower-cost non-physician practitioners, and clinical throughput targets are sharply escalated. In many emergency departments managed by corporate staffing firms, a single attending physician is tasked with overseeing up to 4 non-physician providers, while simultaneously managing a continuous queue of high-acuity patients. This model drastically increases the cognitive load and legal liability borne by the supervising physician. Under current tort law, the attending physician retains ultimate legal responsibility for diagnostic errors or adverse outcomes occurring under their supervisory umbrella, even when they were physically unable to evaluate the patient directly due to high patient volume. The resulting risk environment has caused medical malpractice insurance premiums to surge, further incentivizing experienced clinicians to abandon clinical practice entirely or transition to non-clinical corporate roles. The friction is equally intense between federal oversight bodies and state-level healthcare authorities. The federal government, through the Centers for Medicare and Medicaid Services, or CMS, continues to enforce strict reimbursement penalties tied to patient satisfaction scores, known as HCA-HPS scores, and specific readmission metrics. Health systems that fail to meet these arbitrary benchmarks face significant financial clawbacks from federal Medicare disbursements. To protect institutional revenue, corporate hospital management passes these metrics directly down to individual doctors as mandatory performance KPIs. Physicians find themselves caught in a direct paradox. Federal guidelines penalize hospitals if patients are readmitted, yet corporate management demands rapid patient discharges to free up beds for incoming elective procedures, which generate higher profit margins. Physicians who refuse to discharge patients prematurely face internal disciplinary reviews or non-renewal of their clinical employment contracts. The human cost of this administrative impasse is documented in rising rates of psychological morbidity among medical personnel. Standardized psychological assessments administered to clinical staff reveal unprecedented levels of depersonalization, emotional exhaustion, and moral injury. Moral injury, a clinical term borrowed from military psychology, describes the deep psychological distress experienced when a professional is forced to act in ways that violate their core moral or professional ethics. In medicine, moral injury occurs on a daily basis, when physicians are forced by institutional rules, insurance denials, or time constraints to provide care that they know is substandard, incomplete, or delayed. A prominent incident illustrating this structural dead end occurred at a major Midwestern health system, where an emergency physician was formally reprimanded by hospital administration for spending 45 minutes managing an unstable, critically ill patient in the resuscitation bay. The administrative citation noted that the physician's extended presence in the trauma bay caused a backlog of low-acuity patients in the waiting room, directly impacting the facility's door-to-provider time metrics. The incident led to the resignation of 3 senior emergency physicians from the facility within 30 days. The crisis is further exacerbated by the crushing burden of educational debt that follows young physicians into their professional lives. According to data from the Association of American Medical Colleges, the average medical school graduate carries over $200,000 in educational loan debt, with a significant percentage owing upwards of $300,000 at high interest rates. During the mandatory 3 to 7 years of residency training, young doctors earn modest stipends that barely cover basic living expenses in major metropolitan areas, allowing interest on their principal debt to compound continuously. By the time a physician completes training and enters full clinical practice in their early 30s, they are locked into an immediate financial imperative to generate high income simply to service their debt obligations. This financial trap prevents early career physicians from reducing their working hours, switching to lower volume practices, or taking